feel very strongly that the body wants to be in symmetry. And it doesn't need to be forced there. It doesn't need to be dragged there. It doesn't need to be pummeled there, but it needs to be there. And if we create enough space and if we create enough safety, those joints will happily go to their homes.
Thank you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Pittis.
Hi.
Hi.
Would you like to take a moment to exhale?
It's been a great day. It's been a busy day, but it's been a fantastic few days.
Oh, that's good. Tell me.
I think I finally did just ask the universe to send me some simple nerve pain people because I've gotten quite a few of them.
Yeah.
And I wanted to talk about something before it falls out of my brain because it literally just happened in the clinic. And we talk sometimes about feeling the frequency. Like there's some patients that don't feel it. And then what do we do if we don't feel smush and they're not in pain in that moment and they don't feel the effects of FSM?
Okay.
Do you know what I mean?
Yeah.
So the question was, how do you know if it's working?
Fair enough.
And I had to stop for a second because so many times, like we have people that come in who are in pain. So pain is like that first marker of it's feeling better. The pain is going away. The pain is getting a little bit better. That will always help lead you on the right track, I think. And then of course we have testing or range of motion. But if somebody isn't really restricted and doesn't have a lot of pain and also doesn't feel FSM, doesn't get stoned or floaty or dwarfed, and you as a practitioner don't feel smush, how do we know it's working?
Fair enough. Yeah.
Do you want to know my answer?
Yeah. Tell me, because I have a nerve pain story too where...
Okay, this isn't quite my nerve pain story, but I do think, like anything, some things just take time. So I said, because you don't have pain in this moment and your pain is intermittent, the treatment, the hypothesis, the plan doesn't just end in that hour session of the room. So I always want to know, how do things feel when you got home? How do things feel before you go to bed? How do you wake up in the morning? So I said, let's not panic that we don't know that it's working in this moment. Let's just see how you feel tonight. Let's just see how you feel tomorrow. And if you don't feel any different, this isn't the only tool that we have. This was just one hypothesis that I created today. And if it didn't work with the 3 machines, tomorrow we'll pivot and we'll try something else. So I think that I just wanted to say that out loud to some of the practitioners that are listening, who we can get frustrated when we have those variables. And sometimes we are blessed with the person that walks in with the 7 out of 10 pain, that we can knock it down to a 2 and increase 30 degrees of range of motion in the shoulder. But sometimes we don't get those people.
That's okay. That's not fair, but I got it.
Yeah. So one of the questions we were also talking about is, how do you know if it's polarized positive or alternating? Because we were talking about the different types of current.
Okay.
And if the person doesn't feel anything alternating and they don't feel anything positive, then how do we know which is which?
Fair enough. So how do you know?
I'm a numbers person. So I go with statistics. Like we say, most people, we start with an alternating current for most people. I see a lot of athletes, so my default is actually polarized positive.
Fair enough.
Always have to have a starting point, and then we pivot from there.
Yeah. And then, so you try it positive, and then if that doesn't work, you make it alternating? Or if that makes it worse, you make it alternating?
For the athletes, yeah, I'll start positive. And then if I'm not getting the results that I want, then I'll go alternating. And then for the people that are maybe not the super elite athletes, I'll start alternating and go positive. Like, I think there's just, and then the other question is, when do you change the current as far as alternating and positive? And then when do you just change the frequency that you're on? There's so many questions that I had, so many things that were bubbling up this morning.
Well, yeah, this was during the seminar. We had an outside patient, speaking of questions bubbling up, and this lady had a history of chocolate cysts, an ovarian cyst that was superficial and hard. And I worked on the abdominal adhesions, and she left with her pain at a 2. And then the next day she came back and I said, "What's your pain level?" And she said, "That's about a 6." I said, "Where?" And she pointed to her lower abdomen where I had just worked the day before and gotten rid of this ovarian cyst. After I worked on the ovarian cyst, I ran 18 and 62 for 30 minutes because she has Ehlers-Danlos and the blood vessels are fragile.
Yep.
And nothing worked. And I went, it can't be that easy. So I got on my Pelkey wheel and I ran it down from about T4-5 on her abdomen down to L1. We forget that the very low strip just above the pubic bone is the L1 nerve root. And I got to L1 and she said, "Oh, that's icky." L2, L3, L4, L5, and not S1. Yeah, L1 to L5 on both sides. And the only place she felt pain was what is that noise? Did you just turn a fan on?
It's my computer.
Oh, his computer's making noise. Anyway, the only place she felt pain was in her lower abdomen. So I had a towel on her low back and I ran 40 and 396 from her low back to her abdomen. And that gradually got less painful. So I moved it to a towel on her feet and 140 and 396 polarized positive from her knees to her feet. And at the end, there was no pain. And her naturopath was in the clinic at the conference, and they programmed her custom care for Ehlers-Danlos and ovarian cysts and inflammation in the uterus, disc repair, and SI joint repair, and 40 and 396 polarized positive. It took me close to 40 minutes to eliminate all the other visceral possibilities for lower abdomen pain. I treated her appendix, her cecum, her sigmoid, her uterus. It couldn't be that simple. It couldn't be something as easy as nerve pain. And it was.
Right.
That's not fair.
No, I think I think like we're owed some of these easy ones once in a while, to be honest.
Fair enough. Fair enough. Yeah, that seems fair. They wouldn't be easy for anybody else, but they are for FSM practitioners.
It is amazing, though, the amount of patients that I see with this quote unquote easy to fix nerve pain that were told they needed surgery.
Yeah.
And it's just,
Why?
let me just try.
Yeah.
But I do think it all comes down to what is the saying? If all you have is a hammer, everything is a nail.
And if you don't have a hammer and what shows up as a nail, you're in trouble because you have a nail. And there's nobody else that has the ability to treat nerve pain. And the nail shows up and you go, "That's good. I have a hammer. Hang on 1 second."
Right.
And there you go.
So let's just keep going with this nerve pain, because if you can start treating nerve pain confidently, I do think that will make your practice explode, because there's always some component of nerve pain is pain, right? Like pain is pain, nerve pain is nerve pain, unless it's not nerve pain and it's coming from somewhere else.
Unless it's from a facet and it looks like C8, but that's another conversation.
Right. And we have to talk about that other conversation, because I had that patient, remember I was telling you they wanted to inject the bicipital tendon. And I think I shared the results of the MRI with you, because I'm like, this is not shoulder pain, this is neck pain. And then you have an MRI. Let's just pivot and talk about this for a second. I had a patient with shoulder pain. Now, I don't know about you, but if somebody comes in a year ago with pain in the right shoulder that we fix, and it goes to the left shoulder 6 months later, to only go back to the right shoulder, it's not the shoulder. And I knew it wasn't the shoulder because the frequencies for cord, nerve, dura, facet, and disc were the frequencies that helped the shoulder pain. And for people who are listening, I'm doing bunny ears for the quotes, because it wasn't just shoulder pain. Shoulder pain doesn't go left to back to right again throughout in a year's time.
Yeah. And even without that, the pattern recognition part of it is that when it's a disc in the neck, there's going to be pain in between their shoulder blades that they think is from the rhomboids. And it's like explaining to people the pain in between your shoulder blades is never, ever the rhomboids, or even the thoracic paraspinals that are pulling on that disc that's rotated, the disc. And they go,
Right.
huh? And then they get the supine cervical practicum where you can do disc repair on one machine. 40 and 396 is the whole first part of it. And then in order to get the shoulder to work properly, you have to do the subscap. And this seminar, you would have been so proud. This seminar, there's this really tall chiropractor that had this shoulder that didn't work and limited range of motion, a little bit of impingement and whatever. And we did subscap and the bursa and actually a bit of the labrum, and just got the humeral head in position. And you run torn and broken in the labrum, and then just wait for the deltoid to go smush, and then the humeral head just slides into the joint. And then the other shoulder, he said, I have a slap tear that's 13 years old, and they did Prolo to repair it. I went, okay. So the next free-for-all seminar, his team treated the subscap, and then we treated torn and broken in the labrum, and we had to work around. We actually had to do scar tissue in the joint capsule because the Prolo had glued the labrum tear to the joint capsule. So we had to dissolve that and just gently wiggle the humeral head around. Then we went to torn and broken in the labrum and just tilted the humeral head and let it find its way as the muscle relaxed. It dropped into the joint, and the look on his face was worth the price of admission. And then, because I have Kim now talking in my ear along with the bird, it's very crowded in there, I had him put his arms out in front of him, and we released the lats from the long thoracic nerve and the serratus, and then had him pinch the lower trap, had him bring his shoulder blades down, and then had him contract his serratus, and he couldn't find them. And it's put your arms out and then just bring your shoulder blades back. No, Don't contract your rhomboids. Just use, and then you dig into the serratus. So just use these. Oh, and pretty soon he's stabilizing from the bottom. And the abduction that was okay before, all of a sudden you could watch lower trap, serratus, teres, infers, all fire in order without even doing increased secretions in the cerebellum.
Wow.
It was awesome.
I feel very strongly that the body wants to be in symmetry. And it doesn't need to be forced there. It doesn't need to be dragged there. It doesn't need to be pummeled there, but it needs to be there. And if we create enough space and if we create enough safety, those joints will happily go to their homes. And I think in this description, how when you talked so eloquently about that humeral head just wiggling right back into that space because the adhesions between the labrum and the capsule, which are very common when you have conservative healing going on, so non-operative, you get those adhesions there that creates the stability that's great, but sometimes it goes crazy. So when you get that joint, whether it's in the shoulder or a facet, when you create that space and the safety for the joint to go there, it will go there. And then when you need those supporting cast members, AKA the stabilizers and the co-contractors, to come back online again, they will happily come online again because it's safe to do so. To your point, maybe you don't need to ram increasing the secretions to the cerebellum or the midbrain or to those other areas. And yes, it could be helpful, but things will fire when it's safe to fire.
And sometimes you have to run 40 and 89 because what was fun was and I don't understand why, this group particularly caught on because we're doing it earlier and earlier, the connection, the pathway between the sensory and motor cortex. I want to reach out and pick up this water bottle. And that message goes from there to the midbrain that either says, yes, you can, except you can't use the long head of the biceps or the short head or the teres major or the infraspinatus, but you can reach that. But so the message has to be cleared by the midbrain, the hippocampus and the thalamus, and then it can go to the cerebellum, and the cerebellum looks at the messages and says, pick up the water bottle, inhibit this, contract that, avoid that, move that way. Oh, okay, I can pick up the water bottle. When you fix the periphery, especially in somebody like this very athletic chiropractor or the athletes that you work on, the kinesthetic pathway, the coordination pathway is already facilitated. And the midbrain recognizes more quickly in a kinesthetic and athletic patient. It recognizes more quickly, that doesn't hurt. And the cerebellum says, hey, I bet I could move that muscle because it doesn't hurt now. And the thalamus says, yeah, it doesn't hurt. And the sensory cortex says, I don't care how you manage it, just pick up the water bottle. And it's the difference between treating athletes and pain patients. Pain patients don't have that kinesthetic pathway that's facilitated. They have a pain pathway that's facilitated. And no, sorry. And so I think that's the difference between the patient populations.
Yeah.
And recognizing who's who.
Right. When you have a quote unquote normal person, so let's use the example of a cashier who's scanning groceries all the time.
Oh, dear God.
So I have this person. We'll call her Sally Safeway. She's scanning and scanning and scanning, and it's the same rotation movement of the arm, and they get quote unquote carpal tunnel. So treating the pain, treating the nerve, that is easy But when they have to go back to work, how do we convince our hypervigilant midbrain, who is looking for a threat and going back to work is going to create threat? So using 40 and 89 during that rehab process can really help with that, because she has to go back to work. This is the job that she supports her kids with. And for the time being, it is what it is. But we talk about sometimes, when do you use 40, 89 and when do you use these frequencies? If you know this person has to go back to that movement pattern that is painful and is, for all intents and purposes, now deemed to be unsafe, use it right away. Use it during the treatment. I don't want people to be afraid of not or using it too early or not enough or too long. It can be very helpful in these situations.
40 and 89 used for 30 to 60 minutes is not a drama.
Right.
And for those if you're rehabbing somebody like Sally Safeway and you do the subscap and you repair the bicep, well, that movement, you're going to run into the teres minor being 124 and 77, the little tendinopathy at the end of the muscle. Get the muscle to relax, then treat scarring in the nerve and vein that go into the muscle, and then all of a sudden the shoulder drops back by 2 inches. And then you fix the partial thickness tendon tears. It's all internal rotation, so the subscap has got an opinion. And then when you get the periphery done, yes, you're running 40 and 89 as you're treating it, but I would say the same way that you get a chiropractor to do this with his shoulders, when you finish her shoulder, you raise your table or you take her to a counter in your clinic and you have her do the motion that she's going to do at work. One hand on the keyboard, one hand on the belt. And you have her do that motion while you're running 40 and 89 and 81 and 84.
Yeah.
But then we talked about it at the seminar. The core keeps changing. Anyway, we talked about at the seminar, when we took somebody with spastic diplegia and got rid of the spasticity, running 81 and 10 and 81 and 84, he hadn't walked in 29 years. He hadn't walked without a spastic adductors and legs and toe walking and all of that. Okay, so now his legs are all smushy. He has no idea how to walk. So we had him stand up with his feet on a towel and had him first just shift weight with his leg muscles relax, and then step forward, step back, step forward, step back, step forward, heel strike, weight shift, practice all the individual movements in walking before you ask him to walk. So breaking down the movement. Yeah. And letting him practice while you're manipulating the nervous system. Why would you do that? Because you can. I love that part.
And when you slow down a movement pattern, and we do this a ton in the sports, and I have these neat videos of breaking down everything from a soccer player running to an Olympic weightlifter doing a clean and jerk and a snatch to a hockey player taking a shot and a stride. When you slow it down, you have time to create that safety because it's slow and it's controlled. But you also have the benefit of the proprioceptive awareness. So when you're slowing something down, even like what you talked about, that initial weight shift, just standing there, and I'll cue, I want you to focus more of your weight, transfer that to your left side, and then just watching this way. Now go to your right, come back on your heels, go to your toes. Perfect. Now try that eyes closed. When we close our eyes, we're really relying on those joint kinesthetic receptors. And so when all of that nervous system support of the supporting cast members that are typically in the background that don't even have lines get to participate in the movie, everybody's so happy. And again, those joints start to feel safe. And when movement feels safe, that's when we can really get benefit.
Yeah. And then cueing things like settle your weight into your butt.
Mm.
Use your butt. And I walk with my legs. No, you actually have to
Walk with your pelvis first.
Yes, do it with your pelvis. I guess pelvis is better, but some people don't know what their pelvis is. Everybody knows what butt is.
Absolutely.
And it's being able to put it all together.
Yeah.
For people that worry about being new at this, when it took me 40 minutes to figure out that her lower abdomen pain, it couldn't be nerve pain. L1 is a nerve in the lower abdomen. I've done everything else that should have worked. It wasn't that. Her pain level's a 6. Nerve pain is a 5 to a 7, so that's a 6. I wonder if it's nerve pain. It's just fascinating. And then explaining to an athlete. So I have a family of tennis players that's been coming in. Each one of them has different biomechanical eccentricities or difficulties. And the boy and one of the girls, it's subscout and lat. And then teaching a 16-year-old tennis player who has a coach but no trainer.
Right.
That's okay. Never mind. No one ever told them that the power in their stroke comes from their legs, their butt, and their low back. And they look at you like you're from Mars. And you have to explain that their low back is connected to their internal rotators, is connected. If you look at where the pec major connects and where the lat connects, there's a reason they're that close.
Right.
And all the power, if they know to look for it, comes from their legs, their butt, their low back, and then their arm has to be strong, but the arm can't do it by itself or it's going to get injured. And they all three came in with injuries. That's because you have a coach but no strength trainer that knows about tennis.
Right.
Only one of the three had Ehlers-Danlos, and she would get into a match, and the weirdest set of symptoms, I thought it was psychogenic for, 2 visits. Then I figured she's the only one with Ehlers-Danlos. We put knee braces on her, and her legs never get weak during a match. It's the ligaments and tendons and the amount of muscle that it takes to stabilize the knee that makes her legs weak.
Right.
So it's 3 different players, 3 different mechanisms of injury, all that FSM could fix.
Right. And like a tennis player isn't a tennis player, right? A hockey player is not a hockey player, a runner is not a runner. Like these are the activities that person does. But I think to your point, we know that FSM is not just throw on an Ehlers-Danlos protocol and everybody's going to get better, or thrown on, I don't know, workout recovery or DOMS. Like it's not about that. Yes, these are great starting points, and those are all ideas that can be used to create a protocol for that person. It's continually just reiterated with every conversation, every podcast that we have, and every person I see in the clinic. Is you have to find the driver. You have to find the root cause of what is causing the condition. And yes, running inflammation or scarring or torn and broken can be very helpful at taking the pain down while you're thinking about how did we get here? So it's not just A channel, B channel. It's not just pathology tissue. It's how did we get here?
And it's like putting all the pieces together. Colonel Mustard in the library with the Terry's minor, Peck minor.
It's that crime scene all over again, all those little clues that lead us to what that story is. And I think when we get really good at pattern recognition, of course, there'll be that curveball that's, oh, I really thought it was just the shoulder. And you're like, no, it actually was just stenosis, or it was just a disc. And there are curveballs. And of course, we try to be as comprehensive as possible. But when you get those patients that get better, and they get better for a week, and then they come back, it just didn't last that long. That's when you can start reevaluating your hypothesis and saying, okay, it's great that it helped for a little while, but there's still layers that you're missing either on the pathology or the tissue.
Oh, I have one. There's a patient that came in with this long history of mold, MCAS, lifelong asthma. Then she got a PhD. She's a psychologist. That was in her history. And this was like the fourth or fifth time I've seen her. So we treated one thing at a time, and I treated the asthma, and I treated the GERD, and I treated the vagus, and she has a custom care, and she's starting to sleep better. And then yesterday, she came in and she said, oh, I forgot to tell you. Oh, I know, last time. She said, can we work on my adrenals? And I went, sure. So I put in support, adrenal support. And she came in yesterday and said, she was a whole new person. And I went, how did your cortisol get so low? So she explained early childhood stress, moving to a bachelor's, then a PhD, then a job as a PhD psychologist, and with 20 suicidal patients, where she was on call for 24 hours a day, and she was working clinically almost 80 hours a week.
Wow.
For those of you that are not licensed as psychologists, full-time practice as a psychologist is no more than 20 to 30 hours a week. I said, how did you work 80 hours a week? My boss was insane. And that's when her adrenals failed. Oh, and she's had asthma forever. And every time they give her steroids, her adrenals dropped. And then a naturopath someplace, God bless all the naturopaths that are listening, a naturopath that she saw along the way, her salivary cortisol was in the morning was 2 or 4 instead of 27. And the naturopath looked at it and didn't prescribe hydrocortisone. Really? And then 2 years later, they did another salivary cortisol, and the levels were 3 or 4. Normal is 27. They didn't prescribe Cortef. So just adrenal support in the morning, and she's doing better. But her problem is she doesn't really wake up until 9 o'clock at night. So the diurnal rhythm, it should be, your cortisol should be high in the morning and start to drop at 6 or 7, and should be the lowest at 9 o'clock at night. First thing you lose before your adrenals completely crash is the diurnal rhythm. The other thing is, in Ayurvedic medicine, she's totally a Pitta, which means the high time of the day is 10 in the morning until 2 in the afternoon, 10 at night until 2 in the morning. And I said, so here's the deal. We're going to run. I said, what time do you eat? She said, 8 o'clock. Right. You need to eat dinner no later than 5:30, because you need to eat dinner, go for a walk, wind down, run quiet adrenals, and you need to be in bed. Take Ben. I don't care how you drug yourself to sleep, but you need to be asleep by 10 o'clock before that magic spring hits.
Right.
And then her husband is sitting there Googling this, and he says, hey, exercise-induced asthma is made worse by low cortisol. Because as you exercise, you don't have endogenous steroids. And so the asthma protocol never gave her much relief. Why is that? Because the problem was the fact that yesterday was the first time she ever told me that her measured cortisol levels were basically zero, twice, almost 8 years ago. Yikes. So we did a nighttime quiet cortisol, and I bumped the times up for the morning. And then I wrote a cortisol noon. So it's like taking 2 doses of Cortef, one to get you out of bed. I said, this you run while you're still in bed. Don't even get up. And then this you run at noon, as long as it doesn't make you too jacked up, as long as it wears off by 6 o'clock. And so we had a plan, and it helped that I'd been through complete adrenal failure at one point in 2002 or 3.
Yeah.
And isn't that cool? And it just all the pieces fit,
and so there's a lot to talk about with your story, because we're going back to finding the cause. The asthma protocol didn't especially work. And some people would just say, oh, FSM doesn't work. And I get that sometimes from people, especially patients who have seen other practitioners that just slapped some protocols on, didn't give them very much instruction, didn't tailor it. And of course, they're going to say FSM doesn't work because those protocols weren't right for them or their condition or their tissue or all of it.
And even treating her asthma didn't work because I wasn't treating the cortisol, which is what because her asthma is specifically exercise-induced, and that's the one that's made worse by low cortisol. Who knew?
You.
Well, now I do.
And it's nice when you can look in hindsight when all those boxes fit together and all those checks and balances work. And it does just verify your hypothesis. Now, the other thing I do want to talk about also is sometimes these things are not just done. You can identify all these little pieces, and then a year later or a couple months later, something else will pop up. And it's like the game of whack-a-mole, right? Where you're just like, now what? And again, it's just going back to that original history. Maybe you missed something, or maybe something was just like underlying. There could be pieces of the history that really just didn't come up during that time. But then people start feeling better, and then they're like, oh, now I want you to look at my left hip. I totally forgot about it, but about 20 years ago.
And then there's the conversation we had at the 5-day. FSM is like truth serum. That people get floaty or stoned or whatever. And all of a sudden, oh yeah, I forgot to tell you about the time whatever. Yeah.
Yeah.
It's pretty fun.
And that's great too. It's really strange that there aren't any questions. I keep kind of going back down to look to see.
I just looked down there too, and it's like Leaf said hi.
Yeah.
And to you and me, and then it's either we're being really good or everybody.
Or maybe we're just explaining everything perfectly. But
maybe we're getting better at this.
It's so funny that you say that, because I had a patient / FSM clinician come in. I see quite a few people in the Bay Area who we've trained throughout the years, and they come in it's really fun when a practitioner comes in because you can talk shop and geek out, but it's also hard because I have to stay focused on the task at hand, which is treating them.
Yeah.
And then explaining why we're doing this. And somebody last week said, "Oh, I just can't wait till I feel competent and confident in this." I'm like, "Yeah, me too." And they're like, how did you do? I'm like, "Yeah." And I'm sure if you ask Carol, she will say the exact same thing. Like there's no
2 days ago, it's lower abdomen pain is L1. I talk about it in the seminar. Remember L1?
right.
Totally missed it for what, 4 hours of sessions, 2-hour sessions. Find it the last hour of the last session.
Yeah.
Yeah. Sure.
But this is what I love about what we do.
Me
And
too.
it reminds me of running. You never, like, running is never easy. Anybody who starts running is hard. Somebody that wins the Olympic marathon, it was hard. It's always hard. You just get a little bit better at dealing with the hard.
Mm-hmm.
And that's really how I feel about FSM. It's always complex and there's a lot of layers and there's a lot of moving parts. You just get a little bit easy. The pattern recognition gets easier. The hypothesis being formulated gets easier. But
And figuring out that the frequencies never don't work. So when I treated her viscera in the lower abdomen, I ran out of tissues
right.
and conditions. And it's okay, it's not that. What else is down here? And my hand did this band across her abdomen. The only thing that goes there is the L1 nerve root. Pattern record. The frequencies never don't work. So
Right.
when that stuff doesn't work, it means that's not what it is.
Right.
And then, I think we learn it a bit at a time.
Yeah.
First, you follow the recipe, supine cervical practicum, then the supine shoulder. Supine lumbar in the core is always totally fun because after that, they're turned loose. And you have to throw them out of the room at 7:30 at night when the course is supposed to be over at 6.
Right.
It's always fun.
Yeah.
Yay. See, we ask for questions and they appear. There we go.
I'm glad they're coming in. Sometimes they come in with 2 minutes to go. One of them, would the equivalent FSM treatment for humans work with animals?
Yes.
Yes. Yeah.
Slow version, yes. The anatomy, you have to look. If so, what would be the approach to calm down a male dog if his female bunkmate is in heat? There isn't. You cannot defeat nature. No, pheromones. A fence is the way to calm down a male dog, and they cannot be bunkmates as long as she is in heat. That is just unless you want puppies. And the scenario, no.
Yeah.
No.
Yeah.
When you are running multiple machines at once, how do you know which frequency is working? You don't. You really don't. You set them up if you know for sure, like you test patellar reflexes and they're +3, then you know there's a cervical or thoracic disc involved. So you have to check the thoracic nerve roots. They're fine. C5 and 6 are icky. 7 isn't too sure about whether it's icky or not. Babinski is downgoing or equivocal, so it's not a surgical neck. So you know for sure you have to treat the disc. How do you know it's working? It's a protocol called disc repair, so that's how you know it's working. Then you treat nerve pain in the arm or arms that are bothering them. And then because we described central sensitization and spinal cord sensitization, you know for sure that you've got to treat at least 40 and 10 for the spinal cord sensitization. Why? Because that pathway is up on the slide and you know they're connected. There's no way to have nerve pain for 3 months or 6 months or 2 years without having spinal cord sensitization. And how do you tell if central sensitization, 40 and 89, is working? Because before the treatment, they were, and during the treatment, once you put on, so you treat the disc, you treat the nerve, you treat the spinal cord, and then you put on 40 and 89, and the blink rate slows down, and pretty soon their eyes are closed. And, or you feel for smush.
Or you can just pause the machine. If you only have two and someone's, oh, I don't know what's running, but man, it feels good. And if you have two custom cares or even a precision and a custom care, you can usually look and be like, okay, it's not the concussion in Vegas. It's making them feel good at this point. It's the torn and broken and the whatever. Just pause the machine and see if that does anything, or 5 machines, or, but a lot of times 7, like, yeah, you're just showing off at that point now. But
Yeah.
I think, like you said, a lot of the times you can just look to see what's running. And a lot of the protocols that we're running, even though you've got 7, we talk about like running things in the background. And I think a lot of times those are like nervous system, emotional, sometimes it's gut related. So there's so many different approaches. And Dana makes a good point here too. When they were treated for disc repair, it wasn't immediate relief, but rather woke up the next morning without pain. So that kind of like circumvents to what I was starting with. How do you know if it's working if the person doesn't have a lot of pain when they come in to see you? Maybe they're seeing you on a quote unquote good day, because that happens a lot with athletes. I'm sure it happens the same with people that you see from out of state that come in. It was really bad last week, but today's actually a good day. So we want to see, yes, is it working in that moment, but is it better that night? How is it when you wake up? How is it 2 days from now?
And how do you do the exercises that are going to get it to last?
Stay, exactly.
How do you create a stable state?
Yeah. So Dana, great point. They were saying, I was irritated when I left after 2-hour treatment, assuming it didn't work, but the result the next morning was miraculous.
Yay.
And thanks for writing that, because we do see that sometimes where people see us for a while and they're like, I don't think it really worked. I don't feel all that much different. So I always do say, I want you to take notes how you feel tonight, how you wake up tomorrow, and how you feel a full 24 hours later, because that helps me figure out what I need to do for the next treatment.
And that's why the treatment plan is always twice a week for 4 to 6 weeks. You see them Monday and Wednesday, Tuesday and Thursday. You always see them 1 or 2 days apart, so that either what you did the first time completely worked, or it worked for 24 hours, then it wore off,
Right.
or what you treated the first day is now all fine and dandy, but it created, you don't need one of the compensations that you had in place because of the original OWI, which is now fixed. There was a compensation in place the patient didn't know about that is now not necessary. And now you have to treat that.
Right. It's very rarely the point of pain or the area of complaint that somebody walks in is very rarely the culprit.
Or the only culprit.
Chances are the quote unquote shoulder pain started in somewhere else in the body, and it's just that squeaky wheel that gets the grease right now that brought them in.
There was absolutely no one, like zero. There was no one that will walk into your office and ask you to put your fingers in their armpit. They will come in and say, I have bursitis, or bicipital, or I have shoulder pain, or I can't lift it. But there's nobody that's going to walk in and say, would you please put your finger in and treat my subscap? Nope.
No.
Especially if they've ever had their subscap worked on by anybody else.
I was just going to say, sometimes the shoulder people say, you're not going to put your thumb in my shoulder, are you, in my armpit? And I'm like, I am, but I'm going to do it in a way that I won't have to peel you off the ceiling in an hour. And they're like,
yeah, sure.
How are you? And then you do it.
Yeah.
Because I think in the most painful areas, subscap, piriformis, QL, the deep rotatories in the back, what am I missing? Those really deep muscles, again.
Oh, the psoas.
Psoas. Like
13 and 60. It's like as close to Harry Potter as we get. Go on. It's
But yes, Harry Potter, that's great. But my point is, like, even the best manual therapists on the planet, and I've had the privilege of working alongside a couple of them, the tissue that we're trying to access is so deep. The psoas attaches on the lumbar spine, people. And here we are thinking we're going to access it by just going through the abdomen. It doesn't work like that. But with FSM, it just, and I'll beat this phrase up to death, it does the heavy lifting for you. So you don't have to traumatize all that tissue on top of it. So the patients that have had the elbow in the piriformis and the thumb and like in all the places, it is your responsibility and your privilege as a practitioner to really explain how the treatment is going to be so different because of FSM.
yeah, yeah, and explaining that the headache in the back of their head is from the C1, C2, C3 facet. No, I have a headache back here. Yeah, but it's coming from your neck. And that's why there are posters on your walls that say sclerotomal pain. And see, is that your headache or this one? Oh, that one. There you go.
Right.
Now they believe you because they see it on a picture on a wall that was made by somebody else besides you. You have backup.
Yeah. Yeah, those maps are great because I think it's also very validating when patients are like, oh my God, that purple little map, that's me. I'm like, okay, great. That we just took out 10 minutes of the question and answer period of today. And so I get to just jump right on to that because without those maps, sometimes it is really hard to explain it. And it goes down to that pattern recognition. And when you can connect all the dots and when you can connect it so quickly, you just can hit the ground running a little bit faster.
And every time you treat somebody, Christy Hughes used the phrase, this is N of one medicine. Every patient you treat is going to have some similarities, but they're all going to be different. And so there's a patient out there now, it's a practitioner's dad, and he has pain on the top of his foot. And he's a patient at the VA, and they're doing injections, they're doing different meds that make him, and it's like there's no nerve that goes to the whole top of the foot. I said, has anybody looked at his tib anterior? And she went, what? There's a trigger point in the tib anterior. It's the only one that I know of that refers pain to the top of the foot. How do I know that? I've been looking at these trigger point charts for 27 years.
Right.
It's right there. Oh, the nerve conduction study said it wasn't nerve, so what else hurts? And why doesn't gabapentin work? Well, because it's coming from a muscle, not a nerve. Okay.
So many different avenues that you can take to formulate your hypothesis, whether it's chiropractic training, neurology, a chart, Chinese medicine. Like we get to the places that we need to go, many different pathways. But that's a great phrase. It is an N of one. And it's great when it's an N of 13, which is what we're compiling for post PRP results right now. So I'll take that.
And how you get to where you are depends on where you started. So if you started as an acupuncturist, and I had a physical therapist in the class say, I can't treat somebody's kidney. I can't treat somebody's liver. And I said, of course you can't, but you're not treating the liver.
Right.
You're treating trigger points in the obliques and the right upper quadrant that come from the liver, we think, but we're using the frequencies 40 and 35. And somebody in your board says, okay, you treated trigger points in this patient's right upper quadrant obliques. What do these numbers mean? 40 and 35 means that the trigger points in the obliques in the right upper quadrant went away. Yeah, but what are the numbers for? The numbers are frequencies, and therefore getting rid of trigger points in the right upper quadrant obliques. What's 13 and 60? those two happen to be really good at getting rid of trigger points in the psoas. But what do they mean? They mean that the trigger points in the psoas go away? Because it's outside your scope, certainly, to treat the irritor, but your scope is to treat the psoas.
Exactly.
Yeah.
And my alarm's going off.
We did it again.
We did it again.
I missed you last week.
I know, but I know you were having fun doing the practicums weekend in Troutdale. So
that was a whole week. It was core.
Great. Because it wasn't the weekend, it was a Wednesday. So the core. And did you have a big class?
We had 15.
That's a wonderful number.
Yeah. And I had one patient from the outside who came with one of the practitioners, but it was 3 tables of 5 and a bunch of PTs, a couple of chiropractors, one osteopath, massage therapists, acupuncturists, PTs, chiropractors. There are no MD, one nurse practitioners. So it really is the only technique class I've ever been to that has every profession with a license to touch somebody.
Yeah.
And so we just have a wonderful time because I have to take them from where they all start in all their different buckets of training and bring them down the FSM pathway to see how their training of origin leads them to where they're going to end up and how they're going to approach FSM. I really like the diversity of our community.
Yes.
And how to bring them together in a collaborative venture whose goal it is to change the world by changing one patient's life. That's a neat phrase, a collaborative venture whose goal it is to change the world by changing one patient's life.
I love it.
I
love how you just come up with these things.
And if you're not here to change the world, what are you here for? Pretty fun. And now your alarm is really yelling at you because it's 4 minutes after.
I told it to be quiet, and it's
we're used to it.
Shush me. Anyways, fantastic. Thank you for coming.
Yes, thank everybody for coming.
And we'll be here same time, same place next week, I hope.
I think we are. Yep.
I'll be here.
I'll be here. I will see you next week.
Sounds good. Bye, everybody.
Bye.
The Frequency-Specific Microcurrent podcast has been produced by Frequency-Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.